HPV vaccine is one of the most cost-effective vaccines that we have in the world today. And this comes after 9 years of trying to introduce the vaccine. And so it's a great time to celebrate. And it's with the support of partners like Gavi, WHO, UNICEF, and other domestic and international partners. So today we have the quadrivalent vaccine that's going to be offered as a single dose in the schedule of the National Immunization Program for girls 9 to 14 years of age. We've accomplished the first 16 phase, the introduction in the first 16 states in October 2023. And now we face the work of introducing it in the remaining 21 states by May, as the president has said. And I think it's such a remarkable achievement, even though it's much later than we expect. But one of the key things is that Nigeria is on the way to making HPV vaccine available for all eligible girls. You recall that this is not the first time that HPV is available in the country. HPV vaccine is available in the country. We know that it's been available in the private sector for several years, but it's only been available to parents who can afford it, parents who know about it. And that leaves the vast majority of our girls unprotected from the devastating effects of cervical cancer, as we've talked about it. So it's not enough to offer the vaccine into the immunization program free of charge. We must make the vaccine not only available in the public sector, we have to make sure that every girl has access to it. Parents must know about the vaccines. They must believe in the safety and the benefits. They must also allow their daughters to be vaccinated. We can't let girls who are out of school or those who are living in remote rural areas or urban slums or in other vulnerable conditions go without these vaccines. We have to make concerted efforts. In girls who are living in communities besieged by bandits and terrorists, we still have to reach them with this vaccine. They cannot be left behind. So what do we do? What do we do? That is why this partnership with MWAN is so important. At IVAC, our mission is to accelerate equitable and sustainable vaccine access to everyone, no matter their circumstances. And we do this by generating evidence, synthesizing information, and forming partnerships like this. So we consider this, our partnership with MWAN, to be crucial because it's going to help amplify the work that we're already doing with civil society organizations and young people and young people across the 21 states, where we are conducting a community engagement sensitization to make sure that before the second phase of the vaccine rolls out, that the communities are ready, that they have increased knowledge, that we dispel misconceptions, and we know how dangerous misconceptions can be, that we can generate demand for HPV vaccines, that community leaders are champions. In this endeavor, we are really, really privileged to be able to work with you medical women. You are caregivers. You are available in health facilities across Nigeria. You are indispensable in this, our shared mission to empower communities to make informed decisions and let their daughters be vaccinated. So as we gather in this virtual space to celebrate the power of collaboration, the power of vaccines, I want us to renew our commitment to serve humanity with compassion and integrity. This is what we do well as medical women. I want to thank you so much, every single member of MWAN, for your invaluable partnership and dedication to improving the health and life of Nigerians everywhere. Thank you very much.
Thank you so much, Dr. Chizoba Wanodi, for that beautiful goodwill message. And thank you for finding MWAN worthy of this beautiful partnership to accelerate equitable vaccine access to everyone, not just those who can pay, but everyone in Nigeria that needs it. So thank you very much. We'll take another nations. And so let's welcome, oh dear, sorry. Okay, so we can still welcome the Pediatric Association of Nigeria. After that, we can take Pathfinder. Let's welcome Professor Ekanem Ekure. Professor Ekanem Ekure. Let's have the goodwill message from the National President of the Pediatric Association of Nigeria, Professor Ekanem Ekure. If you're here, please, could you unmute and give us your goodwill message?
Thank you very much for that introduction. The President of the Medical Women Association of Nigeria and the International President, all distinguished immunization stakeholders in the room. Please permit me to recognize the past President of PAN and one of the speakers today, Dr. Dorothy Esangwedo, a past President of Pediatric Association of Nigeria. Good morning, ma'am. We're really happy to have you in the room. I bring you greetings from Pediatric Association of Nigeria. I thank the MWAN President, Professor Rosemary Ogu, for inviting PAN to be part of this webinar titled Strengthening Partnership for Community Action in the Primary Prevention of Diseases, Cervical Cancer as a Case in Point, and the National Phase 2 HPV vaccine rollout. As we know, immunization currently prevents 4 million deaths annually. But the success of immunization is predicated on high coverage, occasioned by high demand and utilization. Immunization is again on a rescue mission for women with the HPV vaccine, which prevents cervical cancer, the fourth commonest cancer in women globally. Cervical cancer kills over 300,000 women annually and is the second most common cause of cancer deaths in women in Nigeria, killing about 8,000 women yearly. Partnership is definitely the way to go. I recall that it was in February this year that we reached out to MWAN to be part of our training of national immunization champions to help create a pool of resource persons who can be engaged by the respective government and immunization partners to fight misinformation and disinformation during and stroke or after the introduction of HPV vaccine to strengthen immunization program in general. This was done in partnership with International Pediatric Association, with the IPA president himself, Dr. Naveen Thakur, in attendance in Lagos. Professor Rosemary Ugu gladly obliged and was one of our speakers. We trained 110 national immunization champions comprising of pediatricians, nurses, and media personalities located in all the states in Nigeria and FCT. They're already doing great things in their states. Subsequently, we are working to increase that number to more than 330 with trainings in all 6 geopolitical zones in Nigeria. In the last 1 week, training has been completed in Enugu, Kanu, and Uyo. I got back yesterday from one of those trainings. Training is taking place in Sokoto right now. There will be one in Gombe tomorrow and Ibadan and FCT next week. I'm therefore delighted that MWAN is taking this message on this platform today. As pediatricians, we're interested in what will happen to our children in the future. But most importantly, we recognize that the loss of a mother has a direct negative impact on the physical, psychological growth, and overall outcome of children. So as an association, we are committed to promoting immunization priorities in Nigeria, thereby creating an enabling environment for the introduction and scale-up of the HPV vaccine. We congratulate the president and members of MWAN for this webinar. Let us strengthen our partnerships, amplify our advocacy, and work tirelessly to protect women's health, thereby indirectly promoting the well-being of our children. Thank you very much, and God bless you all.
Thank you so much, Professor Kanem. I see that you were also to speak for the Nigerian Cancer Society. Would you do that in the next 1 minute before you drop the call? Would that be okay?
No, the Nigerian Cancer Society is here.
I don't think I'm speaking for Nigerian Cancer Society.
They are
Okay,
here.
good.
They are here.
I'm sure they're there. Thank you.
Pathfinder is next.
All right, thank you so much. Thank you so much. You talked about strengthening partnerships and amplifying our advocacies, and that's what M1 is about. Thank you so much, Professor Ekanem. So our next goodwill message will be coming from another of our strategic partners, the Pathfinder. I will have the country director of Pathfinder, Dr. Amina Dorai, to give us her goodwill message. Dr. Amina, if you're on the call, please, let's have your goodwill message. We're very excited to have the opportunity to work with Pathfinder.
Thank you very much, Dr. Agala. I hope you can hear me and see me.
Yes, we can.
Great, thank you. So the president of Medical Women's International Association, our committed icon, and my elder sister, Dr. Eleanor Nwadinobi, our esteemed and hardworking president of the Medical Women Association of Nigeria, our dear Professor Rosemary Ogu, my sister and one of the immunization champions in Nigeria, Dr. Chizoba Wonodi, and the Pediatric Association of Nigeria, President Representative Professor Ekanem Ekuri. I also know that our father, Professor Ladipo, is here, and all our Amazons at the state level, that's the M1 state presidents, our special guests, ladies and gentlemen. On behalf of Pathfinder Nigeria, I am sending you warm greetings, good morning, and thank you for taking out time from your busy schedules to join us at this webinar. The theme of this webinar is strengthening partnership for community action in the primary prevention of diseases, which underscores the critical importance of collaborative efforts, which has also been mentioned, in combating diseases like cervical cancer. Our Pediatric Association of Nigeria president has talked about cervical cancer being the 4th most common cancer in women globally, and the high incidence that we have in low and middle income countries like Nigeria is really unacceptable. Cervical cancer, as we all know, is caused by persistent infection with the human papilloma virus, and studies have shown that prophylactic vaccination against the HPV and screening and treatment of pre-cancer lesions are effective strategies to prevent cervical cancer. The good thing for our country and all country governments is that these are very cost-effective interventions that have been tried and tested across the world. But in countries like Nigeria, we know that there are major inequities which drive lack of access to national HPV vaccination programs, cervical screening and treatment services, and also some social and economic determinants which continue to keep this disease that is preventable, but it always continues to be on the radar. As we proceed, it is imperative to recognize the significant role that vaccination plays in safeguarding the health and well-being of our girls and also our women. And by ensuring access to HPV vaccine, we are not only protecting our girls from cervical cancer, but we are also empowering them to lead healthier lives. Medical Women's Association of Nigeria's mission, as we all know here, is to serve humanity in pursuit of positive health programs through state branches to the entire Nigerian people. And they have an emphasis on women and children, and they employ up-to-date knowledge of delivery systems acquired through world-class medical training. And we're happy that the members, have good visibility and influence at the community level. Ladies and gentlemen, what better organization for Pathfinder to partner with in this whole process than MWAN? At Pathfinder International, we are proud to partner with the Medical Women's Association of Nigeria, the Nigeria Cancer Society, to support the government's initiatives aimed at enhancing HPV vaccine awareness and uptake in 3 states, Kaduna, Kano, and Lagos. Through these effective and collaborative efforts, we aim to create a future where every girl has an access to life-saving vaccines and they're enabled to live and thrive and also fulfill their potential. As we delve into these discussions surrounding the national phase 2 HPV vaccine rollout, let us reaffirm our commitment to collaboration, innovation, and equity in healthcare delivery. Thank you for joining us today, and I look forward to enriching conversations and insights that will emerge from this webinar. Thank you, and over.
Thank you so much, Dr. Amina. Yes, MWAN is very excited to work with Pathfinder, and the 3 states are working extremely hard to ensure that vaccine awareness is upscaled. Thank you so much. The last but not the least goodwill will be coming from the Nigerian Cancer. Hello, anyone hear me? Hello.
We can hear you now. We can hear you now.
We can hear you, ma.
Oh dear, so sorry. Maybe network glitch. But can we have the representative of the Nigeria Cancer Society give us his goodwill message? Is Prof here, Professor Ladipo? Sir, please go ahead. Kindly unmute and give us your goodwill.
Hello?
Yes, we can hear you.
Yes, sir, we can hear you.
Yeah, hello. It's like you called Professor Ladipo, my grandfather.
Sorry. Please,
I quickly muted myself, even though you called the president of Nigerian Cancer Society, but calling Professor Ladipo made me to quickly mute myself and go back into my shell. A very good morning to everyone on the call. I am actually on transit, but I will have to pack and say a few things. My name is Dr. Adamu Al-Hassan Umar, the president of the Nigerian Cancer Society, the umbrella body of all cancer-related NGOs and individuals in Nigeria, a very close ally and life partner in progress to the Medical Women Association of Nigeria, the Pediatric Association of Nigeria, and indeed the Medical Women International Association of Nigeria. I'm glad to be here today. The erudite Amazons have actually said everything which was capped by our country director of Pathfinder International, Dr. Amina Dorai, also an MWAN member herself. So I will not say much because so much has been said during the goodwill messages delivered by these Amazons. Now, the Nigerian Cancer Society, the brand which I represent here today, is actually very proud to be associated with this program. and is glad to be in close working relationship over the years with the Medical Women Association of Nigeria and their vast network. The beautiful thing about our collaboration with MWAN is that most, if not all, of the members of Medical Women Association of Nigeria, and of course, by extension, our mother body, the Nigerian Medical Association, are members of the Nigerian Cancer Society. So I am actually in working with my family members, so to speak. And I want to, on behalf of the Nigerian Cancer Society, applaud MWAN for all the giant efforts they are putting in, especially when it comes to the issues of cervical cancer. Now, vaccine hesitancy is something that is real. It's something that has been here with us right from so many years ago. The phase 1 rollout of the national rollout of the human papillomavirus vaccine has demonstrated something. That vaccine hesitancy is not only amongst the poor, it's not only amongst the rural dwellers. You look at states like Lagos that is recording far below average in terms of uptake of HPV vaccine. This goes to show you that there is more to vaccine hesitancy than meets the eye. Hence the importance of awareness creation, hence the importance of explaining the reasons behind vaccine hesitancy like what we are having here today. So like this,
okay.
Programs like this, projects like what we are doing with the Medical Women Association of Nigeria, social support from Pathfinder International will translate into palpable results in terms of increased awareness on this disease, in terms of increased uptake of this vaccine that has almost 100% protective mechanism against human papillomavirus vaccine. So I thank MWAN for organizing this, and I want to employ all of us to listen attentively so that we can translate the message across, because this is like a training of trainers on immunization. So be rest assured, by the time we get this message, we will pass it across, we will cascade it down so that the awareness will go around. Once again, thank you very much for considering it worthy to give the Nigerian Cancer Society a space to say a goodwill. I wish us all the best, and I wish us a very fantastic morning. Thank you very much, and over.
Thank you very much, Sadamu Al-Hassan Umar, the president of the Nigerian Cancer Society. Thank you for bringing to light some very pertinent issues. And with that, we come to the end of the goodwill messages, and we're going straight to our technical presentations. Just a quick tweak to the agenda. We're going to keep all the questions to after the fourth presentation. As you would have seen, we are talking about almost the same thing. So the question you may have for the first speaker may be answered by the second or the third. So we're going to do our presentations quickly. We're about 10, 12 minutes behind schedule. And then after that, we'll go on to the question and answer. Thank you so much. And join me to welcome for the very first presentation this morning on the overview of expanded program on immunization in Nigeria, including the status of the recently introduced vaccines reaching the unreached. To take that presentation is none other than a past president of the Medical Women's Association of Nigeria. That is a past national president and a past president of the Pediatric Association of Nigeria, a worthy elder of the Medical Women's Association of Nigeria, Dr. Dorothy Esangbedo. And of course, she's also a member Nigeria Immunization Tag team. Yes, please join me with an emoji of a clap to welcome Dr. Dorothy Esangbedo to the microphone. Ma, please, if you're with us, kindly unmute and take it away from here. Thank you.
Thank you very, very much, Madam. First of all, I want to apologize. I'm having technical issues here. So I'm operating from two equipments.
Right.
So
It's fine.
I hope you'll be able to, I hope you're hearing me.
Yes.
First of all, I want to say a big thank you to the president, the international president of Medical Women International, Dr. Eleanor Nwadinobi, for her kind words, and to the president of the Pediatric Association of Nigeria, Professor Ekanemi Kure. I, on the same time, would like to, first of all, thank the president, the national president of Medical Women Association, Professor Ugu, and her team for having me at this forum. I'm very pleased to be here, and I'm very glad to see the comradeship of women at different levels. I thank you so much. I have been asked to speak on overview of EPI in Nigeria. Will you share, are you giving me, can I project my slide? Hello? Can you hear me?
Yes, ma'am.
I'm trying to,
Please, Ma, you can share. It's fine.
it's fine. Okay, yes, but which of my equipment, you just watch out for what I'm doing so that, can you see it now?
Not yet.
Okay, sorry. That's what I was
Not
trying to
yet.
Can you share from the one where we're seeing you?
The one where, no, let me, that's going to be more difficult because that's my phone.
Okay.
So I'm trying to share from the other equipment. Can you please take me to
Yes, we can make you a host with the other equipment.
the other equipment? Yes, thank you. Sorry, I'm sorry about this. I don't understand why this is happening. Can you? Hold on a minute.
Yes, we can see your screen, ma'am.
Can see your
Yes,
screen.
I'm trying to, yeah, okay, thank you. Thank you very much. I'm sorry about the breaking transmission from my end. Okay, slideshow. Thank you so much. I've been asked to speak on overview of EPI in Nigeria, including the status of recently introduced vaccines and how to reach the unreached. My talk will cover a short history of EPI in Nigeria, the immunization coverage in Nigeria, the recently introduced vaccines, which a lot of people have spoken about a few minutes ago. I will also talk about zero-dose children, and I will talk about mixed opportunities and mixed communities and efforts to reach zero-dose children in Nigeria and the challenges in EPI program. The EPI program, as was said earlier, is a WHO initiative that was established in 1974, 50 years ago, to develop and expand immunization program throughout the world through improvement of access to available vaccines. It is modeled on the successful global smallpox eradication program. And initially, the goal was to make available to every child in the world by 1990 vaccines against 6 diseases, which we all know: diphtheria, pertussis, tetanus, polio, measles, and tuberculosis. Since then, of course, there have been several vaccine preventable diseases that have been developed. In fact, to date, there are at least 26 vaccines against infectious diseases. And there are many more prospects in the pipeline. Of course, you see, I have included there tuberculosis. We have BCG, but there are other vaccines being developed that to be effective against tuberculosis. Then the EPI program in Nigeria was started in 1976 as a pilot project with the assistance of the World Health Organization and UNICEF. By 1979, the program had extended nationwide, and a 10-year plan of action was developed with objectives and targets. And the delivery of vaccines then were mostly through mobile operations to towns and villages. Only a quarter were administered at fixed health facilities. I'm sure many of us who were young doctors at that time will recall this event. 4 years into the program, an appraiser in 5 local governments revealed that only 10% coverage was achieved. So there has been a problem with immunization coverage in Nigeria, even from way back. And so the EPI program was redesigned. And the target then was to focus mostly on children birth to 2 years and all pregnant women. And that instead of mostly mobile delivery of vaccines, that fixed facilities were to be used for up to 70% of the delivery. Only about 30% were delivered through mobile outreach, which included going to churches, mosques, marketplaces, and schools. The program was executed in phases at that time because Nigeria is a huge country, and of course because of our diversity. And it was necessary to have partnership. Immunization has always been a program of partners. No single organization or government can deliver immunization. So at that time, the partnership was expanded from a country with WHO and UNICEF. It now included notably Rotary International and the USAID. Immunization coverage, however, as I said earlier, has continued to remain suboptimal, fluctuating over the last decade. There's been some improvement recorded in the past 5 years, but the current immunization rate is just 57%, far from the target of 90%. The WHO UNICEF estimate of national immunization coverage reveals that only 23% of Nigerian children were fully immunized in 2021. This is not a change, no significant change from the 22% in 1995. Many children are therefore under-immunized or have never received a single dose of vaccine. So if you see in the last decade, for instance, you can see this graph to show that there's been a lot of fluctuations and that we are back to our 2018 rate of 57% coverage, national immunization coverage rate. The initial EI schedule covered, as I said earlier on, just 6 vaccines, if you recall this schedule as of that time, that is 1976, 78. But as of now, we have continuously added more vaccines. In 1995, we added the hepatitis B vaccine, but it became more readily available in 2012 when the pentavalent vaccine, which contains DPT, pertussis, tetanus, hepatitis B, and Hib, was introduced. Then in 2004, we introduced the yellow fever vaccine, and in 2012, we introduced the Haemophilus influenza type B vaccine, the Hib, as pentavalent vaccine in the EPI schedule, in the routine immunization schedule. And in December 2014, pneumococcal conjugate vaccine was introduced as 10-valent vaccine, PCV10. And in 2022, we introduced the rotavirus vaccine. Recently, as you have heard other speakers highlight, the human papillomavirus vaccine was introduced in October 2023. And this last month, March 2024, meningitis 5-valent vaccine, ACWYX, was introduced. And we are now awaiting the introduction of malaria vaccine. So we now have a very busy national routine immunization schedule, as you can see, as I have just displayed. And you see now that human papillomavirus vaccine is being induced at the age of 9 years and is to be delivered as 0.5 mils intramuscularly in the deltoid, in the left deltoid for girls. For now, we're saying for girls. I hope in future we will have enough vaccine to extend it to the boys as well. Then we have, therefore, a situation where we have under-immunized and zero-dose children. Worldwide, a total of 67 million children missed out on vaccination between the year of 2019 and 2021. With vaccine coverage levels decreasing in 112 countries. Of course, this must be mostly due to the COVID pandemic. UNICEF's State of the World's Children 2023 revealed that 12.7 million children in Africa missed out on one or more vaccinations over a 3-year period. 8.7 of this did not receive a single dose of vaccine. Africa has the highest number of under-immunized and zero-dose children. Again, WHO now came up with another agenda, Immunization Agenda 2030, IA 2030, which is an agenda, a global vision and strategy for vaccines and immunization for the decade 2021 to 2030. It is leveraging on the lessons we have learned from previous programs to target challenges posed by infectious diseases. The vision, once again, is a world where everyone, everywhere, at every age, receive full benefits from vaccines for good health and well-being. It aims to maintain the gain in immunization, recover from disruptions caused by COVID-19, and achieve even more by leaving no one behind in any situation and at any stage of life, which is a little different from the initial EPI, which was not focusing on life cycle immunization. This one is a life cycle focus of immunization. Now, who are the zero-dose children in Nigeria? Nigeria is the second largest contributor to zero-dose children in the world after India. Nigeria contributes about 25% to the burden in Gavi-sponsored countries. And the total estimate of unvaccinated children in West Africa is about 4.8 million. Nigeria is the largest contributor. And UNICEF estimated that 18% of under 2-year-old children never receive vaccine, which is about 2.2 million using the 2021 WUNIC data estimate. There are zero-dose children in all the 774 local governments in the country. However, majority of the zero-dose children is in northern states. Out of the 100 local governments prioritized by government for intervention to reduce zero-dose children, 90 are in the northern states of the country, as you can see displayed on the graph. Who are the zero-dose children? Zero-dose children are those children who have not received any basic routine immunization. But for operational reasons, I know Chizoba is here, so this is her pet subject. I see she just published a paper on this in the last year. For operational reasons, zero-dose children are defined as children who have not received a single dose of diphtheria, tetanus, and pertussis-containing vaccine. They are usually untraceable or are not tractable by governments. Most of them live nomadic lifestyle. They are displaced children by conflict. and natural disasters, which have increased due to, of course, climate change. There are children who are poor. Majority of them live in poor households, surviving on less than $1.9 per day. And many of them are displaced because of food insecurity. Some, and this is what is important for medical women to take note of, are unreachable because of gender-based systematic exclusion. So nearly 50% of children who are zero dose live in 3 geographic areas. The slums in urban area, slums in Lagos have zero dose children. The remote hard to reach areas and the conflict areas. Those are the high density areas of zero dose children. Gavi, the Vaccine Alliance, launched in 2020 the ZIP program, that is zero dose program, working in partnership with CSOs and governments to reach the unreached for zero dose children across the Sahel and Horn of Africa, as displayed in the map. The goal is to reduce the number of zero dose children by 25% by the year 2025 and by 50% by the year 2030. About 50% of children, why do we focus on the zero dose children? We focus on them because about 50% of children that die from vaccine preventable diseases are zero dose children. And to close the gap in immunization inequity, it is important that we know that 1 in 8 children still not receiving a single dose of vaccine in low-income country. 2 out of 3 zero-dose children, they live in households below poverty line. Locating zero-dose children is a track to locating other healthcare inequities because they go hand in hand. 49% of them are likely to have mothers who received antenatal care. And still about 49% of them are less likely to have mothers who had an institutional delivery. So tracking zero-dose children helps to track these other disadvantaged women. And also 38.8% are less likely to live in a household with water or cleaning agents. So tracking zero-dose children helps us to track other deficiencies in the health system. And of course, COVID pandemic resulted in an estimated 30% increase in zero-dose children. What are the efforts being made to reach zero-dose children in Nigeria? The guiding principle of Gavi and indeed WHO is equity. In other words, trying to ensure that everybody has equal access to immunization. Locating zero-dose children is therefore critical to addressing equity in immunization services. Locating zero-dose children, however, poses logistical and funding challenges. Gavi developed the IRMMA framework to help in identifying these children. And this is identify, reach, monitor, measure, and advocate framework. It is to guide Gavi implementing countries, Gavi program implementing countries on how to access Gavi fund by implementing this framework of identifying, reaching the children, monitoring them, measuring, and advocating for them, and to ensure a sustainable reach of zero-dose children and missed opportunities in these Gavi program implementary countries. Now, also it is important to identify zero-dose communities. Under-vaccinated communities have high proportion of zero-dose children and partially vaccinated children. So they go hand in hand. And usually these are remote rural areas, nomadic groups, urban slums, population displaced by conflict, And of course, as I said earlier, gender bias situations. Why then do we focus on zero-dose communities? We focus on them because, again, these are marginalized communities, and these communities have as I said, has a high percentage of zero-dose children, which is an indication of the communities lacking other healthcare services. And also, focusing on zero-dose communities is a focus on health insecurity. Zero-dose children live in communities most vulnerable to disease outbreaks, and those communities are least equipped to respond to those outbreaks. And focusing on zero-dose communities also is an opportunity to engage and understand the barrier to vaccination in zero-dose communities and to understand vaccine hesitancy. The strategies to reach the zero-dose children are multiple. They include ensuring availability of services, address supply barriers, vaccine confidence and service uptake, and of course, effective partnership, which I had already spoken about. As part of the Nigerian strategy for teen immunization and primary healthcare system strengthening, the National Primary Healthcare worked with partners in August 2022 to update and align on priority local government list based on the MIC and NIC data. A week-long in-person workshop was facilitated by the University of Southampton to estimate immunization coverage data at local government level. And some criteria were agreed on how to prioritize the local governments that have zero-dose children and to align on population data that was gathered. As a result, in line with this, the National Primary Healthcare and the partners were able to use certain criteria. Those who were unimmunized with Penta, unimmunized Penta 1 or Penta 3, unimmunized with measles-containing vaccine, or circulating vaccine, derived polio vaccine, and so on and so forth. And they awarded them scores according to these indices. And as a result, they were able to therefore identify those local governments that need attention. And they came up with over 100 of such local governments across the country. And as I said earlier on, 90% of them are in the northern part of the country. And since 2021, efforts have been made to reach these children. They have tried to as I said, identification of the local governments that have the highest number of zero-dose children. And they have also had to develop strategies that incorporate various strategies to implement how to reach the local government. And in 2022, the National Primary Health Care also reviewed those analysis while incorporating results from the national NIC and MIC data. And in September 2022, based on a more rigorous analysis and methodology, 100 local governments that were identified and prioritized across 18 states. And the National Primary Health Care got support from Gavi to conduct a qualitative study and national strategy on to further identify how to reach the zero-dose children. And in February 2023, National Primary Care reviewed the implementation of the zero-dose at the EPI review and commenced a review committee and commenced routine immunization intensification. The guide to the local government based on these findings were mostly around governance, the delivery of services, the funding, the accountability framework, data and monitoring, and of course the vaccine logistics. And this they did by engaging by the National National Emergency Routine Immunization Coordinating Committee, engaging the local governments to address all these issues. And they also have periodic activities. There are several strategies, periodic intensification of routine immunizations, optimization of reaching every ward strategy, reduce missed opportunities for immunization, optimization of integrated immunization settings, and special approach for security and compromised and hard to reach areas. All these called for activities that spread through both fixed posts and outreach posts across the country. There have been challenges, however, reaching the unreached with vaccinations. The challenges include governance, public awareness and acceptability, and of course, program management. With governance, political leadership change. And so many times, new government, when they change, new individuals come in, and also human resources who were already trained to take care of such programs may also be transferred, and this can affect the immunization program. And also there's been an unstable awareness of the scope and seriousness of the target diseases by the individuals that by the new government, and sometimes unstable political will and varied prioritization of immunization program. And there's also been lack of understanding of economic gains and competing health and non-health programs for prioritization. And of course, security challenges are not only competing priorities, but they are also major impediments to efforts at reaching zero-dose children. And to quickly go through this is the challenge in the program. Usually you have ineffective program implementation to weak program leadership or logistical challenges as a result of infrastructure, insufficient skills for storage and handling, and management of information system, and insufficient monitoring and evaluation of program impact is also a major problem, and very often funding gaps and poor funding coordination and linkages between the national and subnational and management of immunization program is also a challenge.
Prof. Ma, can you hear me?
Yes, I'm rounding up.
Oh, please, yes, thank you. Okay. I thought you didn't see the message. All right,
yes.
Thank you, okay. Please. We are behind.
Immunization program is, there's also one of the main problems we have is lack of public knowledge. We tried to address this with the first National Vaccine Summit in 2012, Dr. Wunodi will recall, where we had a big advocacy in order to focus on immunization. And there's also low public awareness and understanding of the scope of the seriousness of the diseases. These are things that we can address as medical women when we do our outreach to grassroots. And of course, vaccination hesitancy, as earlier alluded to, lack of public demand for immunization program, limited access to primary healthcare facilities, and insufficient community ownership and demand for accountability in immunization program. As doctors, what can we do? Opportunities arise when we have clinical encounters or program encounters with our patients. So we are able to evaluate the immunization status of the children when we do that, and it's an opportunity to educate. We're also an opportunity to educate the parents. It's an opportunity to talk about vaccine acceptability, to listen and educate based on presented context, and to build confidence in health system, and of course to collect data. So just to quickly round off, since we've run out of time, is to say that reaching the zero-dose children, Medical Women Association has a role to not only to educate, but also research, to monitor and evaluate, to, as we are doing now, forming partnership and collaboration in the processes of delivering immunization services, and of course, picking up with evidence for improved funding. and addressing specifically gender-based systematic exclusion through grassroots health education designed to address the various contexts that may lead to inequity and inequality in access to immunization. Thank you for listening.
Thank you so much, Prof. Can we give my round of applause? You know, when someone is in the work, you're speaking from experience, you're speaking from it's not going to be enough for such a presentation. We thank you so much, Ma. We want to inform everyone on the call because we have other people, doctors, other health workers, nurses, health educators, mothers, fathers on this call. And so we know that we cannot discuss everything in one webinar. We're going to be having another webinar in the next quarter. So we would encourage our speakers to keep it kind of brief. Is a mixed crowd. This is not just about medical women, it's everyone else on the call. So thank you so much for that. We're going to go on straight to the next presentation. Our national president is already ready, and I'm hoping that she can do hers in 10 minutes, so that we can buy 10 minutes of our time. So to take reducing cervical cancer burden in Nigeria. Reducing cervical cancer burden in Nigeria. The case for single HPV vaccine dose strategy is the delectable national president of the Medical Women's Association of Nigeria, Professor Rosemary Ogu. Thank you, Ma. Please, you have the mic and try and be brief, Ma. Thank you.
Thank you so much, Dr. Betty. Please confirm that you can hear me.
We hear you loud and clear, ma'am.
Thank you so much. I said Dr. Sangbedo was just into her topic because of what she sees. Do you know what it means to have zero dose children? To have children who didn't get any immunization at all. And so she just kept on and on making a case for her children. We understand you, Ma. Thank you. I'll try and be brief. We will try. We don't have much time. I'm so sorry. And we have our own NEC meeting coming up at 12:30. So whatever we do, we need to be out of here in another 1 hour. And so I'm going to talk about reducing cervical cancer burden in Nigeria. I'm an obstetrician gynecologist. And so I would give that picture. All right, can you see the next slides? Greetings to everyone here. Please permit me to stand on the already established protocols. Greetings, everyone, from the Medical Women's Association of Nigeria. Greetings to all our guests who are here today. It's a pleasure to see all of you. Over 300 people on this call. I am so pleased. Thank you. But we want more. We say we will get to 500. So let's be there. I want to say thank you to those who helped me put the slides together. It wasn't just me, Dr. Toide, Dr. Mustafa, Dr. Maduboeze, Dr. Wana D herself, and Professor Yengidiki. Thank you so much. And so this is what we're going to be looking at today. Cervical cancer. What is cervical cancer? That's the cancer of the cervix, the one that happens at the neck of the womb, where the baby comes out from. It's the commonest female cancer in female genital tracts, commonest here, okay? Worldwide, you will say it's about the fourth, but when you are talking about genital tract cancer, that's happening around the reproductive tract of the female, cervical cancer is the commonest. And so we're talking about cervical cancer having a cause. It's one of the few cancers where you know the cause, and the cause is persistent infection with the human papilloma virus. Persistent infection with the human papilloma virus. And so what's the extent of the problem?
What's the
extent of the program? Okay, we're talking about a very common cancer. It's common amongst women at their prime 30 to 39 years, 50 to 60 years. We're talking about worldwide women dying from the condition every year. It's lots of women, 500,000 women in Africa All right, and 75% of these in the developing countries. And we're talking about because of late presentation. By the time you know there's a problem, it's already too late. Cervical cancer is the one cancer that we know that is 100% preventable. The cause is known. All right, it's preventable. You know what causes it. Why are people dying from it? And we say that over 80% of us, we acquire it. Everyone would have that HPV. All right, but many of us will clear it, okay? So we're free, but some of us will not clear it, and you don't know who will not clear it. So it is best to prevent. It's best to prevent instead of waiting, all right? And persistent HPV infection can cause cervical cancer, as well as other cancers in the vagina, in the vulva, in the throat, and for boys as well, which is why we say we hope we will get to boys. But for now, we're focusing on our girls. And so the World Health Organization is worried, not just World Health Organization, but every well-meaning individual is worried about cervical cancer and the global burden that it shows, okay? We're worried, but we know from studies that have been done, this is one study that I have just put up there, prophylactic vaccination against HPV and screening and treatment of precancer lesions are effective ways to prevent cervical cancer, and they are very cost effective, okay? And countries around the world are working to accelerate the elimination of cervical cancer in the coming decades with a set agreed targets to be met by 2030. What is this global strategy? What is it talking about? It was started in 2018 by the World Health Organization Director General, making a global call for action to eliminate cervical cancer, underscoring renewed political will to make elimination a reality, and calling on all stakeholders to unite behind this goal. In August 2020, the World Health Assembly adopted the global strategy for the elimination of cervical cancer. And every country was charged to go and try to do 3 key pillars, 3 targets. Vaccination, 90% of girls should be fully vaccinated. 70% of women should be screened using a high performance test by age 35 and again by age 45. And then 90% of those identified with cervical disease should receive appropriate treatment. That was the target that was set. And Nigeria bought into this, all right? We know how reporting is in Nigeria. You go to the hospital, you want to go and look for reports of what happened 2 months ago, 2 years ago, you may not be able to find. What we have documented for us is that 12,000 new cases was what happened in 2020 and 8,000 deaths. That is what is documented. We know it is a lot more than that because it is the second most common cancer death amongst women aged 15 to 45. Before now, we keep talking about risk, women at risk, women at risk. The risk factors for cervical cancer are such that you really don't have control over. How do you control early age at first intercourse? How do you control early marriage? How many of us in the audience were able to say, this is when I will get married and this is when I will have first intercourse? Sometimes it doesn't happen the way you think. And so women at risk with these risk factors, these are not modifiable risk factors, really. Sexual behavior of male partner. Do I know his sexual behavior? Multiple sexual partners. Do I know what he's doing? You understand? Patients on treatment with steroids. If I need steroids, you know it's something I need to get. So it's not something I can change. And so when you talk about these risk factors, and controlling risk factors, it's not really fair. As Medical Women's Association of Nigeria, since inception, October, we dedicate to cancer screening. We talk about breast and cervical cancer screening. February, we dedicate to cervical cancer screening. We've been doing screening for so long. We had this mega capacity program in Ebonyi State, nationwide, not just in Ebonyi, in February and March, January, February, March this year. All our partners, you can attest to that. These are things that we keep doing, but we know that even as we're doing screening, there's something that is better than screening, and that is primary prevention. So yes, we continue doing screening. You cannot not do screening. If you look at the targets, screening is part of it. But primary prevention is also something that we should do. And research has found that invasive cervical cancer incidence following human papilloma virus vaccination reduces the development or prevents the development of invasive cancer. Okay, routine vaccination given at age 12 to 13. All right, the studies have been done. If you go on the internet, there's so many studies that you will find. There are also many misinformation, which is why after this presentation, Dr. Wanodi will come and talk to us about frequently asked questions and misinformation. So significant impact of HIV vaccines in reducing the prevalence of vaccine type infection and high-grade diseases has been demonstrated. The evidence is there. All right, the evidence is there. The efficacy of vaccination is best when the vaccine is given prior to the onset of sexual activity and prior to exposure to HPV, okay? In Nigeria, for once, I want to say Nigeria, not forehand. In Nigeria, national immunization programs now include HPV vaccination. We can see from the slides from Dr. Sangbedo that HPV vaccination is to be taken at 9 years. It's there as a national immunization. And so Nigeria is now on the platform, okay? We had the phased introduction that was done in September 2023, and we have the next phase of the intervention coming up in May 2024. And we hope, just like Dr. Wanodi said during her goodwill message, that by 2025, we will have full routine immunization for the HPV vaccination in Nigeria to girls who are 9 years of age. And so as I conclude and as I round up, I want to remind you, I want to tell you that cervical cancer is preventable. Cervical cancer is preventable, yet it remains one of the leading causes of mortality in Nigeria, largely due to poor access to available prevention strategies. Some say, oh, the vaccine is not there, but where it is there, are you availing yourself of that opportunity? HPV vaccination is a major part of the strategies for the prevention of cervical cancer vaccine with a 90% effectiveness. The National Immunization Program, which is on now, is one of the most effective strategies that we can use to prevent this cervical cancer and the mortalities arising from it. Please be an advocate for prevention. Please support vaccination. All right, so I'm going to leave you now with a message that we send to all our MWAN members every month for February, March, April, where we tell you about the month, how the month is going to be, send greetings to you, and wish you the best. For the month of April, we have said, may this month be better than the previous month. Thank you very much. Dr. Betty, over to you.
Thank you so much. It's always a delight to listen to my national president. She's so passionate, just like many of our speakers here on the call. Thank you. Cervical cancer is preventable, and we are all called to be advocates. Thank you so much, Prof. Let me use this opportunity to remind all of us to fill in the Google form so that we have our attendance complete. Ensure that you don't leave this call without filling the Google form for us to know your name and have your contact so that we can invite you for the next webinar at least, or you can reach us for questions. We're going to go on to the next. Thank you. Every presenter has been excellent, has been amazing so far. We'll go on to the third presentation, which is on addressing vaccine hesitancy, frequently asked questions, and misinformation, including lessons from the rollout of phase 1, and none other than the Associate Scientist, John Hopkins, Bloomberg School of Public Health, and one of our own, Dr. Chizoba Wanodi, to take that presentation. Dr. Chizoba, please. You have 15 minutes to take the presentation, but if you do it in 10.
I'll try my best. Thank you. Thank you so much. Can you see the screen? Yes, you can. Okay. So thank you for that introduction. I'm going to go really fast. Can you see?
Can you hear me?
Yes.
Okay,
So,
thank you, ma'am.
So this is my session outline. I'll just give a quick background of our project and talk a bit about vaccine hesitancy and how to address it. And then we will now take the frequently asked questions from our field work so that you can get a sense for what the community is thinking about HPV vaccine. So, and as a form of a background, my organization, the Johns Hopkins International Vaccine Access Center, received funding from Gavi to activate civil society organizations for immunization using HPV vaccination as an entry point. And we're doing this work in collaboration with Direct Consulting and Logistics, who is our in-country partner. And more recently, we've added MWAN to our partnership, for which we're very excited about. So we are working with civil society organizations and youth-led organizations as well as young people on this. So on the right, you can see we start first with training them. So we have 32 master trainers of civil society organizations and 16 master trainers that we just recently trained. They will then go on to identify 10 vaccine champions in the wards where they are going to work in. So each master trainer will work in one LGA. And so in each LGA that they work in, they will identify 10 ward vaccine champions who will then go on to identify each 5 settlement champions. At the end of our project, we expect to have activated more than 17,000 vaccine champions across the country. And this is really important because we're going to need a lot of community dialogues and sensitization to prime and prepare the communities for the vaccination. It's really exciting, the work that's going on, because you can see that when we finish training them and they go into the communities, you see empowered youth, empowered CSOs, even the religious and traditional leaders that we work with are so happy that this information is coming to them. So it's not just information, it's a two-way dialogue that we have with communities so that they have the opportunity to ask questions and have their answers addressed. Now, we want to talk about vaccine hesitancy, but before we talk about vaccine hesitancy, I think it's important for us to recognize that the vast majority of Nigerians actually will take this vaccine or allow their children to be vaccinated. Here is data from a national survey that was done by MPHCDA last year before the introduction of the vaccine. On the left-hand side, we have results from knowledge questions that were asked to parents. So you can see that before the first rollout, knowledge about HPV was quite low, 37%, only 37% knew about HPV. Few of them, only 27% knew about the diseases that HPV causes and all that. So that's on the left-hand side. You see the bars are lower, means that few people had heard about HPV or the diseases or the vaccine. On the right-hand side, we look at these are the attitudes that they have towards HPV infection and the vaccination. Look at the tallest bar there, it's 92%. It says that 92% of the respondents had given their children routine immunization. And then 91% of them said that they would be willing to take their children to receive the HPV vaccine. Although there is still some concern about possible side effects of the vaccine. What this graph is showing us is that there is very little information about HPV in the communities. However, there is a potential of acceptance, high acceptance, particularly among parents who already accept routine vaccination for their children, because you can see that the majority of them have actually given their children vaccination. So there is potentially high acceptance, but there is still a small proportion and also an important proportion of the population that will not take the vaccine or that are hesitant. And we need to address those, that proportion. I think somebody needs to go on mute.
I gave you hosting rights, ma. Maybe you should make me host again so I can be muting people.
Oh, you gave me hosting rights? Okay,
Yes,
I didn't realize.
so you need to do that for me so I can mute these people. Thank you, ma. Please go on.
Okay. All right. So that was before the introduction, right? We saw that quite a number of people would accept the vaccine. Sorry, let me try and find a way to give you hosting rights. I'm trying to figure out how to give you the hosting rights. Do you know the button I need to click on?
Click on my name. There's something at the edge that will say more. You should see something that says
I should
more.
Go to the, okay.
Then make host. Thank you. Apologies.
No problem. Thanks for giving me the hosting rights. Okay. Make host. Okay. Yes. I've given you back.
Thank you. So I'll be muting them now.
Rights.
Please go on.
Okay, thank you. All right. So this data here is from MPHCDA. What we're seeing is the target, the coverage of the HPV vaccination achieved after the phase 1 rollout during the multi-age cohort campaign. What you see here is variation in the coverage rates achieved by states and by age group. Recall that the president of the, I think, Cancer Association of Nigeria talked about Lagos State having low coverage. So you see that 50% coverage in Lagos State among 9-year-olds, and then 33% coverage among 10 to 14-year-olds. And in some of the states where we typically have low vaccine coverage, you see they're doing very well in terms of that Kano, 170%. Why I show this graph is to demonstrate the fact that we cannot take for granted that people will accept the vaccine, or places where have historically had high vaccine coverage will accept the vaccine. We recall that during the first phase, the first day after the vaccine launch, a popular radio host sent out misinformation about the vaccine, and that caused a lot of hesitancy in the field because our CSOs were in the field and they were calling frantically to say, we had to get back to the radio host to rescind the statement that he made. So issue of vaccine hesitancy is always a threat and is something that we should be vigilant about. But nonetheless, Nigeria did pretty well. I think we achieved more than 80% coverage on average nationally. Okay. So why are reasons why people will accept the vaccine? They will accept if they trust the person who is recommending the vaccine to them. So medical women and healthcare workers are top on the list among people who are trusted to provide recommendations for vaccination. So our role is really important. They will accept if they trust their immunization providers. They will accept if they trust the safety and efficacy of the vaccine, which means that we need to provide the information to them so that they will understand that these vaccines are safe and effective and they've been used for many, many years and millions of people have received it safely. And then they will also accept if they understand the burden of cervical cancer and the need to prevent it. So we need to keep this at the back of our minds when we are thinking about strategies to address vaccine hesitancy. So what is vaccine hesitancy? WHO defines it as a delay in acceptance or a refusal of vaccination despite the availability of vaccine services. So if I'm a young girl in an IDP camp and I'm not vaccinated and the services have not been brought to me, that's not vaccine hesitancy. That is lack of access. But where the vaccine is there and you are, or the parent is refusing to avail the child of the vaccine, then it's hesitancy. But it's not a monolithic phenomenon. You can see here that there is a spectrum of vaccine acceptance, from people who refuse all vaccines completely, and then all the way to people who accept all vaccines. What we want to do is to find it somewhere in between, those who refuse but are unsure, those who are delaying, or those who accept that are unsure. This is where we have the greatest leverage to change people's minds. Many times, for those who refuse or who are very strong, entrenched objections to vaccines, they may not change their minds. And so we want to concentrate our energy around the middle where people can move into the acceptance region. Now, what are some of the reasons why people will not accept vaccines? First of all, when there's a knowledge gap, when they don't know about the safety of the vaccine, when they don't know that the vaccines are available, and then when there are a lot of misconceptions about vaccines. Some of the misconceptions we've seen flying around social media is that it causes infertility in girls, and that it promotes promiscuity, and that, you know, why is the vaccine targeted at girls and not boys? These are not unique to Nigeria. Like I said, this vaccine has been used in many countries. So, and some of the misconceptions, you find that these are rumors that were generated outside Nigeria, but because of the ease of social media, is filtering into the country. So there are some that are generated here, there are some that are international, but it's all coming together on our WhatsApp pages and on social media. So that's a big challenge, why people may be concerned about the vaccine. So when we went into the community and we were doing our sensitization with the CSOs, we were documenting the kinds of questions that they had and the issues they had. And this is really important in order for you to craft the right messages. There were questions they had around rumors, right? So there were questions that, you know, is it true that if women can get cervical cancer from using soap to wash their private part? There were a lot of questions about eligibility. So who is supposed to get this vaccine? What is the age range? And there was a lot of interest in men getting the vaccine. Some women were asking if their husband could get the vaccines, and so on and so forth. There were also questions around screening, if they had recently been screened, if they could take the vaccine. There were questions around if older girls could take the vaccine as well. Now, so what we did was we trained the CSOs to be able to respond to these questions when they arose. Then there were questions around how the vaccines work. So what should they do if they get side effects from the vaccine? If there is a risk of overdose with the vaccine, and how long the immunity from the vaccine would last. So these were some of the questions that we got from the field that we now converted into the Q&A that I'll show you in a minute. So we have all these questions. How do we address vaccine hesitancy? The key thing is that preparation is key. You need to be really prepared to answer these questions. You need to know the kinds of questions that are coming out, the conspiracy theories, the rumors, the misinformation. And you need to know your audience, because how you address a 9-year-old girl is going to be different from how you address a 25-year-old man or a 60-year-old community leader. So knowing your audience is really important, so you can understand the social behavioral drivers of their vaccine sentiments and uptake. Then the other thing is knowing the rumors and the misinformation that is circulating. And this you can do by having, there's something they call social listening. So there are actually apps that can scrub the internet, can scrub the social media to see the kinds of conversations that are happening. And when there are new ones that emerge, it can pop up. So you know that this type of misinformation is spreading on social media, and then so you can respond with the appropriate message. So rumor and misinformation monitoring can be done online. It can also be done in the communities through sensitization and through community engagement activities. Now, with that information about the rumors, there is now a strategy that's been pushed, which is called pre-bunking, or in a way, inoculating the communities against misinformation. So when you know that there is misinformation about the vaccine causing infertility in girls, when you go to the communities, you preempt that conversation. You provide that information in small doses, almost like the way vaccines work, so that you have the opportunity to have a dialogue with the community, address their questions, so that when the misinformation comes eventually, the community is already inoculated against it with the knowledge and with the right information. So that's pre-bunking and inoculation with information. And then, of course, you have your usual sensitization, education, and then motivational interviewing, which are slight cognitive adjustments that can be made in the way you provide the information to the communities. Now, there are three things I want to emphasize in terms of addressing vaccine hesitancy. You have to have the right messenger, you have to have the right message, and then you have to have the right medium. I said earlier on, in terms of messengers, healthcare providers are number one. They are the number one trusted messengers. So you as a medical woman, as a doctor, you are in the right position to advocate for this vaccination, HPV vaccine, in your practice, at home, in other social gatherings where you are. So that's a charge to us as medical women. There are also some other trusted messengers, and you wouldn't know who they are until you do the research to find out. But in Nigeria, for the most part, it is religious leaders, it is traditional leaders in communities. Those are trusted people that the community, so we should go to them for them to be advocates for vaccination. There are also influential people. There are social media influencers and political leaders who, when they take a stand for a vaccine or a program, then it influences the community to carry along. And then more importantly, for this HPV, which is a vaccine targeted at adolescents, peers can be very influential. So adolescents themselves, both adolescent boys and adolescent girls. The message is important. The message is important. There are studies that show that for healthcare providers, presumptive communication is an effective way to get people to take their children to be vaccinated. What does that mean? It means that when you're seeing let's say you are consulting with a parent that has a vaccine-age child, as you're talking to them, you would say something like, okay, today, Amina is 9 years old, so she's due for this vaccine, she's due for HPV, she's due for nutritional screening, blah, blah, blah. So you list out the things that they are due for, and you're communicating to them presumptively that this is a service that they should get at this point in time. So that in a way, it's almost like it should be the norm, right? So presumptive communication is highly effective with healthcare providers. When you're communicating, you have to show empathy. Even if people have misinformation about vaccines, say it causes infertility, you don't respond to them, first of all, by maybe judging them or castigating them. You respond to them and say, you could say something like, I can understand why you feel this way, or I can understand that this is a rumor that is going around, but I want to assure you that blah, blah, blah. So you empathize with them first before you give the message. So don't just give the message without empathizing, because what it tells them is that you're actually listening to them. And then some of the messages you can use could be messages that show that accepting the vaccine is a norm. So that's normative messages. For example, you say something like, when we introduced the vaccine in phase 1, more than 3 million children accepted the vaccine, particularly when people are concerned about the side effects. More than 3 billion girls were vaccinated, and we don't know of any major side effects from that effort. So showing that it is the norm and that it is safe is important. And then I'll jump over to the issues around the medium. The medium is important. All these media that I talked about are really key. Interpersonal, one-on-one, when you have the opportunity to talk to people one-on-one is great, because it gives them the opportunity to ask questions, all those questions in their mind, and you respond to them. The media is so important. The media is important in the sense that you don't want them to be a source of disinformation like it was in the phase 1. So making sure that all the media personality are on board and will not be a source of disinformation is key. Social media is critical for monitoring rumors and misinformation and addressing them, and then using influential social media platforms to push out the right information. And then community dialogues are really critical. So, how do we deliver the message? There are some do's and some don'ts. So let's start with the don'ts. When people tell you about their concerns, either about side effects or a rumor that they heard, don't just dismiss their opinion or their concerns. Acknowledge it first. Listen with empathy. And then once you've listened and acknowledged it, then you provide them the right information. Okay? So next thing is, don't impose your opinion on them. We know that people trust doctors for medical information. Even at that, we don't impose our opinion on them. We have to ask clarifying questions so that we come to a shared understanding, and then you provide the information. When people have misconceptions, don't affirm them, right? Don't say, okay, I agree with you on that. No. You could say, I understand that you may have heard this from somewhere. It's not the same thing as saying, I agree with you on that. So don't affirm misinformation, but equip people with the right information to make an informed decision. Of course, don't judge them. Our attitude towards them is so important. Let's be polite, respectful, and then seek permission to share our knowledge. So these are some of the do's and don'ts of delivering the message. So, and I think I should be rounding up soon. I have a series of frequently asked questions and some answers in the remaining slides that will be important for us to, take home with us. So here are some of the questions that we get. Why is the vaccine only for girls? Well, the HPV vaccine will be given only to girls because women are majorly affected by cervical cancer. So we tell them that research has shown the vaccine to be effective for young girls. And then for Nigeria, we are prioritizing giving it to young girls because of global vaccine shortage. We don't have enough to give to both boys and girls. Dr. Sangwedo talked about maybe down the line we'll give it to boys, which is true. But right now, there's just enough for girls. And then from 2025, only girls who are 9 years of age will be eligible to receive the vaccine for free in Nigeria. So the way the government has done it is that it will introduce it in a campaign mode, targeting 9 to 14. And then from now to 2025, all 9 to 14-year-olds can get the vaccine in the routine program. Thereafter, from 2026, it will now be limited to only one age cohort, which is the 9-year-old. So the 8-year-old girl of this year will now become 9 in 2026 or of next year, so to speak. Become 9-year-old and now become eligible. So it will only be 9-year-old that will be receiving the vaccine going forward from 2025. How do I know if my daughter is within the age bracket? Sometimes in the communities, parents, especially parents who have not gone to school, don't know the age of their children. So what we advise them, the CSOs to do, or the parents to do, is to use major events that have happened around the time the child was born to deduce the age of the child. So was the child born during Jonathan's time, or was the child born during Buhari's time, or was the child born when certain things in the community happened? That way you can kind of pinpoint how old the girl is and if she's eligible. Another thing is girls who are at the cusp of the age limit, right? So the question is, my girl just turned 15 years last month. Can she still get the vaccine? Yes, she can get the vaccine, but not through the vaccination rollout. So they are being, well, the thing is, they are not asking for birth certificates, to be honest with you. So they go to schools and then they ask the teachers to, produce girls who are between the ages of 9 to 14. So it may be that the 15-year-old girl, could be vaccinated or not. So, but the point is, the eligibility stops at 14 years of age. Can older girls or women get the vaccine? They can get the vaccine, but not through the government program. The eligibility age is 9 to 14. But if you want to, go to a private clinic to go get the vaccine, certainly you can do that, but it's for a fee that the clinic will determine. Can my son or my husband get the vaccine? Again, it's not through the through the national program. You can get it through the private clinics. When will the vaccination start? So it's important to let them know exactly when the vaccines will start. Will it be free? Yes, the vaccines are free. So another question people ask is, where will the vaccine be offered? So it will be offered in health centers. There'll be mobile vaccination teams going around. It will also be offered in the communities and in the schools. So those are the key areas where the vaccine will be offered. Will we have to pay for the vaccine after this first phase of vaccination? First of all, the vaccine will continue to be free in the programs, but then it's a one-dose regimen that Nigeria is introducing for every eligible girl. But the girls with HIV are supposed to get more than one dose, and there will be a special program to make sure that that happens. People ask about